additional NF1 network webinar coming up in September. We've got 250 people that have registered for this evening's webinar from coast to coast. And if you are an international participant, the call-in information may not allow you to participate. Since we do have so many people that have registered for this meeting tonight, only some of the questions we will have time to answer. So if you have additional questions after the webinar, Dr. Stewart has offered to look at them. Please send the email to me at admin@nfnetwork.org. So now I'd like to introduce you to our presenter, Dr. Doug Stewart. He's from the National Institute of Health, the National Cancer Institute, and he has expertise in NF on the clinical side as well as research. Welcome, Dr. Stewart.
Thank you for that introduction. And as Kim said, she had asked me recently to hold this webinar and focus on two subjects. One, practical medical knowledge that was hopefully useful for everyone living with NF1, and a brief update on research on NF1. So first, by way of introduction, I'd like to give you some background about NIH and about myself. I work, as Kim said, at the National Cancer Institute, which is part of the National Institutes of Health. And the NIH, the picture there shows the main campus in Bethesda, Maryland. So it's suburban Maryland, just outside Washington, D.C. And the NIH is the nation's medical research agency. It's made up of 27 institutes, each with a specific research agenda, often focused on a particular disease or a body system. And there is research on NF1 as well as NF2 at the National Cancer Institute, of which I am part. There's also NF2 and NF1 work done at the National Institute for Neurologic Disease and Stroke. Just a few little facts. The budget for NIH is about $30 billion a year, and 80% of that money goes to about 300,000 research personnel at 3,000 universities across the United States. Several thousand physicians and scientists, myself included, work at the NIH's own laboratories, and you can see the building complex there on the screen, most of which are on the main campus in Bethesda. And in the foreground there is the NIH Clinical Center, and it's the largest hospital in the world totally dedicated to clinical research. And the NIH director is Francis Collins, who back in 1990 headed one of two teams that actually cloned the gene, found the gene that causes NF1. So just a quick background about myself. My training's in clinical genetics and internal medicine, and I came to NIH in 2004 to study why different people with NF1, even with within the same family, can have such different problems with the disorder. And over the years, I've evaluated dozens of families with NF1, and I make it a point to attend the annual NF1 conference, or it's NF1, NF2, and schwannomatosis conference held every year in June. Just got back 2 weeks ago. I've published a number of scientific papers on NF1, and I continue to see people with NF1 in my clinic. And as I said earlier, for today, I'd like to share my top 10, so to speak, useful medical tips for people living with NF1. So getting started, going from number 10 to number 1, although I think they're all important, is first to know about plexiform neurofibromas. So what is a plexiform neurofibroma? It's a congenital neurofibroma. Congenital means that you're born with it, or it's thought to be congenital in most cases. And these are neurofibromas that can affect the length of a nerve or multiple nerve roots. And it's estimated to affect up to half the people with NF1. If you talk to 100 people with NF1 and you say, do you have a plexiform neurofibroma, 30 of them will put up their hands and say, yes, I do. If you take the remaining 70 of those people and put them in an MRI and you do a scan, you find or can find plexiforms in another 20 of those people. So a total of 50 or 50% of people with NF1 have these plexiform neurofibromas. So they're obviously very common. They can cause a lot of problems. They can be clinically silent. meaning that they're there for years or decades and you don't know about them, and I have some examples of that I'd like to show you. Or in some children, we don't understand why this is the case, but in some people, especially as children, they can grow and grow and grow and cause lots of problems, organ compression and so forth. It's because of this, it's hard to predict the behavior of these plexiform neurofibromas, although they tend to stop growing as people get older, meaning into early adulthood. They can cause disfigurement, meaning they alter the shape and form of the body, and they can cause functional impairment. As they get bigger and bigger, they can compress important organs. And at the moment, we don't have any medicines for these to control the growth of these tumors. More about that later. And so the standard treatment is surgery. Surgery is very difficult for these tumors. They can be very large. They can be very vascular, meaning they have lots of blood vessels in them. And so they bleed a lot. And they have a complex shape, meaning it's not so easy for the surgeon to remove them. And they also have a tendency to return, even if a very good, clean surgery is performed. So here are some examples of people with plexiform neurofibromas. You can see this young woman's had multiple surgeries to remove the tumor. You can see the scars. Same thing with this young man. And this is an MRI of a young woman I saw many years ago who had plexiform neurofibromas up and down her spine. She really had no idea she had any of these tumors. She didn't even know she had NF1. She came to us in her late 20s complaining that she had some back pain, and took the MRI, and lo and behold, that's what it is. It's very striking MRI, and it was always surprised me how she didn't really have any symptoms until she was almost 30. So here's an example of how these tumors can be quiet. I met a number of years ago a young woman who was in good health. She slipped on the ice and hurt her left knee in a fall. It didn't get better after a few months, so she went to see a doctor who performed an MRI of the left leg and the knee and found a plexiform neurofibroma, which, needless to say, was a big surprise because she didn't, for a variety of reasons, didn't know she had NF1. So she had knee surgery. Symptoms still didn't get better, and she had an MRI of her thigh, and there was a second plexiform neurofibroma. Now, it was labeled as a second plexiform. I have a feeling it was really one neurofibroma connected by the same nerve, as you can see here. See if it's hard to see the pointer, but in that lower panel you can see the two distinct plexiforms. And as I said, this woman had this tumor in her leg for 30 years and had no idea that it was there. So these things can lurk in different parts of the body without you knowing it. So the number 9 is to know about MPNSTs, know about what they are. And an MPNST is a malignant peripheral nerve sheath tumor. And you may wonder, what is an MPNST? And there I've spelled out what it is, a malignant peripheral nerve sheath tumor. And it's a malignant cancer that develops from plexiform neurofibromas in about 10% of people with NF1. They usually, if they're going to develop from a plexiform neurofibroma, usually develop from so-called deep plexiforms, ones that are deep in the body, not on the surface. However, the important point is that they can develop anywhere they want, and I've definitely seen that. I've seen these MPNSTs develop in places where there are not any plexiform neurofibromas. As with the plexiform neurofibromas, the best treatment is surgical. The sooner the better, because unfortunately they have a tendency to spread. The medical term for that is metastasize. At this time, we don't have any effective screening strategies to predict the development of an MPNST. As I noted earlier, it's about 10% of people with NF1 develop them, but we don't know which 10%. And because of this, early detection is the best approach. So let me give you an example of a patient I saw many years ago. It's a 34-year-old man who came to us with severe back pain. And he had been evaluated by many physicians over the previous 6 months and seen a number of specialists, all of whom sort of focused on their own area of interest. And finally, one of them said, "This has been going on, had been going on for so long, let's get an MRI," which the doctor did. And there is an image of the MRI, and you can see that big bright lesion in the middle of the body is the MPNST, and it's unfortunately very large. And this man had a plexiform neurofibroma there in his lower back. Did not know about it. He knew he had NF1, but he did not know about the plexiform in his lower back. And from there, an MPNST grew quite rapidly. He had surgery and radiation and got better, and then relapsed, and more surgery and more chemotherapy. And so from this, I learned you have a lower threshold. In NF1, often it pays to do things sooner rather than later, and I'll talk about that a little bit later. So in summary then, about plexiforms and MPNSTs, use common sense and be aware, and that means seek help with rapidly growing, painful, or bleeding tumors, or pain that wakes you up at night. If there is a tumor that wakes you up at night or keeps you from falling asleep, that's a warning sign, and you should be checked out for that. As I said earlier, you may have a plexiform neurofibroma and not know it. As I said earlier, not all MPNSTs arise from plexiforms, and they can arise anywhere. Be proactive, and this goes back to the young man I talked about a few minutes ago. Sometimes, as you probably know better than I do, educate your doctor about NF1. Does your back pain or whatever other symptom you may have another explanation? And think, and encourage your doctor to think, which unfortunately is sometimes something you need to do, to think outside the box. Is there more than just a commonplace explanation, like a stretched muscle or a pulled muscle in the case of low back pain? Is it something else? And don't be afraid to seek a second opinion if needed. So, moving on to number 8, talk about watching your blood pressure and thinking about Theos, which I'll explain what that means in a minute. Let me give you an example of a patient I saw a couple years ago, a 46-year-old man who had NF1, and he had a 10-year history of high blood pressure that was borderline. So sometimes it was high and sometimes it wasn't. It was a little bit intermittent. But over a relatively short period of time, 6 months, it became, meaning the blood pressure became more difficult to control. And he developed worsening anxiety and panic attacks and a racing heart, sweaty palms, very uncomfortable feeling. And for a completely different reason, he developed blood in his urine. I think he had a stone, and that's prompted a CAT scan. And on the CAT scan, there was a tumor on the right adrenal gland. And the adrenal gland is this organ that is located, that resides right on top of the kidneys. And it produces chemicals that control blood pressure and sugar metabolism. But there was a tumor there on this right adrenal gland. And he had surgery, and it was determined to be a pheochromocytoma. Sometimes we abbreviate them as a pheo. So what is a pheochromocytoma? Well, it's almost always benign tumor of the adrenal gland. And about 1% of people with NF1 develop these Theos, which is why I'm talking about them tonight. 1% is, of course, not very much. I've definitely seen it myself. I've diagnosed it in people. So it's definitely out there. And Theos produce a chemical called catecholamines that episodically, meaning from time to time, increase blood pressure and heart rate. So that means sometimes you're in the doctor's office and the blood pressure is high, and sometimes it's not high. And sometimes the blood pressure goes up, the heart rate goes up, and sometimes it doesn't. When these Theos release the catecholamines, you get a surge of them in the bloodstream, and they can make people feel very uncomfortable, anxiety, headaches, sweaty palms. These chemicals are the so-called fight or flight chemicals, and they raise your blood pressure and your heart rate in anticipation of dealing with a problem. And they make people feel very uncomfortable if they're around for too long. These Theos are difficult to diagnose because they're unusual and often are not thought of. But the good news is they're relatively easy to make the diagnosis once you think of them. And so this involves collecting urine for 24 hours. This means walking around with a bucket and urinating in a bucket for 24 hours, and then that bucket gets sent to the lab, or some blood tests that can be done. And a CT scan or an MRI is very helpful. And the good news is that once they're taken out with surgery, that's the end of them. Sometimes they come back, rarely, and sometimes they can be in more than one place. So as a matter of summary of high blood pressure, this is true for everyone. Get your blood pressure checked yearly. But in the context of NF1, be aware of Theo-related symptoms, like I just mentioned. Some physicians have advocated everyone with NF1 getting 24-hour urines. I'm not sure if that idea is going to go anywhere, but it's been mentioned because it's, again, relatively common. And bear in mind, especially in children, there's this entity called renal artery stenosis. And renal artery stenosis is blockage of the blood vessels that control blood to the kidney. And this can also result in very high, difficult to control blood pressure. And people, often children, young adults, wind up on multiple blood pressure medications. And finally, someone thinks of it. Again, it goes back to thinking outside the box. And the diagnosis is made by CT or MRI or angiography, which is taking pictures of the blood vessels. And of course, probably the most common explanation for high blood pressure in NF1 is good old routine high blood pressure, routine hypertension that everyone gets. So number 7 goes to screening MRIs. And I mentioned here that there really are rarely needed. Let me talk about that for a minute. So there's no need yet, and again I'll talk about that a little bit later, for routine screening MRIs. Meaning if you get diagnosed with an MRI, there's no need to get diagnosed with NF1, there's no need to have an MRI every single year for most people. Obviously some people who have plexiform neurofibromas or other tumors like optic pathway gliomas, sometimes it's prudent to have an MRI done every year, but for most people it's not necessary. Now there is research being done on this whole body MRIs and looking for plexiforms, especially those deep ones that cause NP and STs, to try to get a sense who may have them and who doesn't. So this may change, but at the moment there's really no need for this. With regards to screening, as I talked about earlier, we recommend blood pressure checks and what I like to call lowering the bar for working up new symptoms. So with NF1, since it's a tumor, it's a disorder that increases the risk for tumors, you and your physicians need to be worried about pain and tumors that are growing. Again, going back to the NP and STs. So lower the threshold or the bar for investigating a new symptom, especially one that's persistent or becoming more severe. And of course, there are a number of regular screening tests, depending upon your age and whether you're male or female, that are appropriate for everyone. Vaccines, pap smears, colonoscopy, blood work for cholesterol, that kind of thing. None of those change because you have NF1. At this time, there's no additional screening that we recommend for NF1. Now, for children, it's a little bit different. Many clinics advocate a yearly eye exam for these optic pathway gliomas, these benign tumors of the brain that can cause problems with vision, up to 7 years. Some people say 8 years. Some clinics advocate doing an MRI at a young age. Others say it's not necessary. It's controversial. Of course, a pediatrician should keep an eye for standard development, whether it's motor skills or learning problems. A spine exam for scoliosis is always a good idea for everyone, but especially for children with NF1 because of the increased risk for scoliosis. A skin exam looking for the surface plexiform neurofibromas is a good idea. And as I said earlier, some have argued a baseline MRI for known plexiform neurofibromas. And if there's an unusual murmur heard on a heart exam, an ultrasound is reasonable to rule out congenital heart disease, which is something we see from time to time in NF1. Pulmonic stenosis is the most common. Again, this is something that usually can be heard with a stethoscope, and that can prompt the ultrasound. So the next item on my list is a sort of a personal favorite for reasons that'll become clear in a moment. And it's a question that I ask the people I see with NF1, and it's a question, do your fingertips ever hurt? Which is a kind of an odd question, but you'll see why it's not so crazy in a moment. So what I'm looking for here are to ask about symptoms of glomus tumors. And what are glomus tumors? They are small, rare, fortunately, benign, but very painful tumors. And they come from the structure in the fingertips, although it's located elsewhere in the body, called a glomus body. And the glomus body is what's called a thermoregulatory shunt. It moves blood around depending upon the temperature. We see them in the general population, people who don't have NF1, although they tend to be a single tumor under a fingernail or a toenail. In NF1, people can grow multiple glomus tumors, so multiple fingers or toes hurt. The good news is that surgery is usually curative, and I say generally or usually curative because I've definitely seen situations from time to time when they come back. And glomus tumors are now known to be associated with NF1, and that's a project that I was involved with, and it was very satisfying to be able to make that discovery. And so this is a picture. I hope this doesn't upset anybody too much, but it's a picture taken in the operating room, and you can see the thumb there, and the fingernail has been removed, and that little ball of tissue in the middle at the bottom of where the nail is the glomus tumor. And they have this little capsule, and they are relatively easy to come out. So it makes it a relatively easy surgery on the fingertip. So glomus tumors present the following way. They have a triad, or a group of three things, often, but not always. They're painful. The pain gets worse with cold temperatures, and they hurt when they get pushed. The fingers get pushed, or touched, or vibrated. And it doesn't have to be very much. It can be very routine things, like turning a doorknob or riding a bicycle. The cold hypersensitivity can also be very minimal, reaching into the refrigerator to grab a jug of milk, for example. About a third of the people with glomus tumors have a bluish discoloration in the nail, and some of the nails are deformed or otherwise abnormal. We don't really know why such small tumors can be so painful, but we know that people with NF1 are at increased risk for developing them, and as I said, not just single glomus tumors, but multiple glomus tumors. And I don't know what percentage of people with NF1 develop them. I would guess less than 5%. But what I've seen many, many times is that there's often a long delay in getting a proper diagnosis. Again, it's an unusual symptom, and it tends to get ignored. My recommendation is if you have these types of symptoms, to ask your doctor to get an MRI of your fingertips, and can often be detected by through that way. And this is a bit of a dramatic picture of a woman with a glomus tumor growing through her skin and deforming her nail there. This is this is more the exception rather than the rule. So, speaking of pain, there are, I believe, several different types of pain in NF1, and I'll go through a list here from probably what I think is the most common to less common. And what I've listed in black is pain, or pain types that tend to be easier to treat. The pain types in red are a little bit more difficult to treat, but they still can be treated. It just takes a little bit more work. So migraine and migraine-like headaches seem to be very common in NF1. The good news is that they respond to standard migraine medications. I found asking people to keep headache diaries and trying to identify triggers can be helpful. The scary thing about headaches, and especially bad headaches in NF1, is that people assume that they have a brain tumor, which is very rarely the case. So often the best approach is some reassurance, medication. Obviously, if things don't get better, to proceed to imaging. The good news with migraines is that they often present with such a characteristic group of symptoms that the diagnosis is more of a clinical one. We've talked about plexiform neurofibromas. I've seen patients and talked to colleagues who've also seen patients with NF1 and plexiform neurofibromas that have a very uncomfortable so-called neuropathic or nerve pain that can be difficult to treat. Again, we don't know why some people develop this type of pain with plexiforms and others don't, but it's a very real finding. The malignant peripheral nerve sheath tumor, the MPNST, can be quite painful, as we talked about earlier, and the treatment for that is surgical. The glomus tumor, again, a little bit uncommon, but has its own unique presentation, as I just discussed. Again, the treatment is to take it out surgically. Chronic neuropathic pain, and what I mean by neuropathic is nerve type pain, and this is this burning, fiery, unpleasant sensation like when you hit your quote-unquote funny bone in your arm. The funny bone is actually a nerve that gets irritated, and that kind of uncomfortable electric feeling is neuropathic pain. And in my experience, I've seen a number of people with NF1 with this type of pain. Again, why some people develop it and others don't, I don't know. The symptoms can be controlled reasonably well with a variety of pain medications. I found in my experience that getting the help of a pain clinic or a pain specialist can be useful. The good news is there are a variety of medications, and people always worry about getting addicted and so forth. In my experience, sometimes you do need to use narcotics, which do have an addictive potential, but sometimes significant relief can come from other medications like gabapentin or Lyrica, which perhaps you've seen advertised. Radiculopathy is another type of nerve pain along the lines of, like I said, hitting your funny bone. We see this more with pain in the spine from a tumor, and sometimes the best treatment for that is removal of the tumor. And then a colleague described what she called neurofibromatous neuropathy, which is these neuropathic pain for people with lots of neurofibromas. I don't think I've ever seen this, but I can definitely believe it exists, if only because it's very similar to other types of neuropathic pain that I listed previously and have seen myself. So why study pain in NF1? Aside from MPNST-associated pain, there isn't much published on this subject. There really isn't much in textbooks or recent reviews, and if you do a literature search of the medical literature, you don't find a heck of a lot. In my discussions with people with NF1 and advocacy groups, such as the folks at NF Inc., pain and I would say depression and anxiety, which often can go along with pain and make it worse, are significant quality of life issues. I think at this moment it's a matter of being aware and educating yourself and your doctors about the fact that pain can be a significant part of people with NF1, and especially with the overlay of depression and anxiety. And it really comes back to, we can't cure NF1 yet, but it's a symptom that can be treated, and I think it can be treated effectively. Sometimes it takes longer than you'd like and some more work, but I've definitely seen people receive lots of relief when they sort of keep at it with trying to get their pain symptoms improved. So what about bones in NF1? This is a increasingly popular topic in the research community. And this is a picture from the American Journal of Medical Genetics from a couple years ago. And the photograph is the bowing of a lower leg of a child with NF1 in panels A and panel B. And this is called tibial pseudoarthrosis. And you can see the x-ray is a rather dramatic fracture of that bone. And the bones in the tibia, the lower bone of the leg, is in some people, again, it's a few percent, it tends to fracture, and again, in people with NF1. And it can be very difficult to heal, and even with casting and surgery, it can be difficult for the bones to rejoin and form normal bone again. So it's really quite a challenging surgical problem. Again, we don't understand why this affects some people, and in very dramatic situations, people have had to have amputations of their lower leg. Fortunately, that's a rare complication. Here's some more x-rays of that bowing, which, as you can easily understand, can lead to fracture. The other thing we talk about with bony problems in NF1 is this sphenoid wing dysplasia, which if you look at that CT scan with the arrows, where the location of it on the left, which would be on your right as you look at this, as you look at the image. Again, this is rare, but for whatever reason, these bony problems develop in this particular bone in the skull. Perhaps of more interest to the more general population of people with NF1 is this issue of fractures in NF1. And this was a paper that came out relatively recently from a Canadian and a German group, and they looked at bone density in NF1, people with NF1, and they found that bone density seemed to be lower on average in people with NF1 than people who did not have NF1. And so the word for this is osteopenia. But in most people with NF1 in the study, it did not quite meet they did not have osteoporosis, which is real weakening of the bone and increased risk for fracture. I suppose the good news here is when I've talked to lots of folks over the years with NF1, I've asked them how many fractures they've had, and I haven't been that impressed with the fracture rate. Still, the bones do seem to have less calcium. They seem to be less mineralized and perhaps less strong in some ways. But whether that actually translates into worse fracture rates, I'm not so sure about. But this is an active area of investigation with regards to developing standards for DEXA scans, which is the preferred method to assess this, and for blood tests to measure bone density. And I think you'll be hearing more about this in the future. At the moment, we don't really recommend anything other than taking calcium and vitamin D. Getting near the end here, know about NF1. Well, what do I mean by that? Well, there's some common misunderstandings in NF1. Most people know that NF1 is not the elephant man disease. It was thought to be for many years. The elephant man, a man by the name of Joseph Merrick, had something called Proteus syndrome, which is even rarer than NF1. NF1 is about 1 in 3,000 people. I'll get to that in a moment. Proteus syndrome is about 1 in a million people, so it's even more rare. NF1 and NF2 are two different disorders. NF1 does not lead to NF2 and vice versa. I've never met anybody with both disorders. I suppose it's possible, but that would be a new one to me if that actually happened. That would be pretty unusual. NF1 does not skip a generation. It can be more severe in some generations and less severe in others, and it can appear to skip a generation. But if the grandfather has the NF1 and the grandson has NF1, it's very, very likely that the father or the mother between the grandfather and this grandson had NF1. In medicine, there are always some unusual exceptions and so forth, but as a general rule, it does not skip a generation. Speaking of how common NF1 is, there are about 100,000 people in the United States with the disorder. It's 1 in 3,000 of 300 million people. It's 100,000 people. There are quite a lot of people out there with NF1. The cafe au lait macules can take some time to show up, but they usually appear on the skin by the time someone's 1 or 2, or very early childhood, and then they stay there and they can fade with age. And then the other important thing to understand about NF1 is it's based on a clinical exam, which means it's a matter of asking some questions and doing a physical exam. It doesn't take very long if a physician knows what he or she is doing. It does not have to be diagnosed using the blood or a gene test, although in some circumstances it can be very useful. And just as a matter of being formal about this, the NIH developed, in collaboration with a number of NF1 experts over the years, a diagnostic criteria. And I imagine most of you know about this, but it's a list of 7 things, and you need to have 2 or more of the items from this list of 7. So number 1 is having a certain number of cafe au lait macules, these birthmarks. Number 2 is having neurofibromas on the skin or a plexiform neurofibroma. Number 3 is having freckling in the armpit or in the groin, which is very common in NF1 and almost unheard of outside NF1. The optic pathway glioma is a benign brain tumor we talked about. It's seen in about 15% of people with NF1. 2 or more Lisch nodules are these benign tumor-like lesions in the eye. They don't cause blindness. They don't cause any problems, but they can be very useful for diagnosing NF1. Or having a bone lesion like we talked about, the sphenoid wing dysplasia or the bowing or the pseudoarthrosis. And lastly, if you have a first-degree relative, meaning a sibling, a mother, brother, father, or child with NF1, that's one of the criteria. So you can mix and match the any 2 items from this list of 7. Most people have many more than just the 2. But armed with this list and knowing what to look for can make the diagnosis in many people in a relatively short period of time. The challenge is sometimes the symptoms or the signs don't appear until over time. So in childhood, you have to wait sometimes several years for these things to show up, and that can be difficult and anxiety-inducing, and that's why sometimes the gene testing can be helpful. Sometimes you have to be smarter than your doctor. I hate to say that, but here's what I mean by that. As I said earlier, you have to educate your doctor sometimes and encourage him or her to think outside the box. And in medicine, we talk about the horse and zebra problem, and it goes like this. If you hear the galloping of hooves, you should think of horses, because, of course, horses are a much more common animal. than zebra. But NF1 is more of a zebra problem. And people with NF1, of course, have common problems too, like low back pain. But you and hopefully your physician needs to think about maybe the explanation for a given symptom is a quote-unquote zebra problem, that it's not just the common, it's something unusual. And it's well worth keeping that in mind. I think it's as true for everybody, but it pays big dividends to know your own medical history. No one can be expected to have this all memorized, but having a copy of your own records is very helpful, including, if possible, copies of MRIs and things on discs. You have to be proactive, especially in the medical system. It's neither good nor bad. It's neutral, and it won't always work to your benefit. So sometimes you have to follow up to get test results and so forth. Don't be afraid to ask questions of your doctor, and if they are not willing to look into it or look it up or find out for you, maybe you should move on to another doctor. Use common sense is something that I've talked about many times before. And the last, and maybe the number one list of medical tips I believe in NF1 is don't smoke, which sounds trivial, but unfortunately I've seen many people with NF1, which after all is a tumor predisposition syndrome, who smoke. And hardly need to go into the details of the health risks of smoking, but especially with NF1, it's just literally playing with fire. So I wanted to shift gears for a few moments, and then we can take some questions about reasons to be hopeful in NF1 and NF2. And I recently came back from the annual NF conference. It's held every year, and they had some interesting statistics. The interesting thing about NF1, NF2, and schwannomatosis is that it appeals to a very large international research community. There are people all over the world who are interested in this disorder for a variety of reasons. The first year I went to the annual NF1 conference, NF conference, it was in 2005, and there were 140 participants. And we all fit into a very modest-sized hotel with a very modest-sized auditorium. And then as of last year, and I suspect the numbers are even bigger this year, there were over 300. So easily a doubling in 5 years, and the conferences had to move on to larger venues. All a good sign, and I've noticed over the years the international flavor of it, physicians and scientists in the United States, Canada, all over Europe, South America, Japan, Korea, China, even the Middle East are involved in this disorder. Now in 2005, when I first got involved with this, the clinical trials to treat really much of anything in NF1 and NF2 were unusual, and now there are more and more underway, and last count there was something about 19 that I had heard about, mostly focused on the plexiform neurofibromas, the MPNSTs in NF1, and the vestibular schwannomas in NF2. There's some unusual clinical trials I'll get to in a moment, but obviously these tumors are the ones that cause the big problems, and so naturally they're the focus of the early clinical trials. The other thing that's exciting, and this is something I'm involved with and getting underway, is sequencing tumors from NF1. So you may be familiar with the huge international effort to sequence the human genome. That took about 15 years and cost $1 billion. Nowadays, with the amazing improvements in technology, doing that takes about a month and costs under $10,000, and the price is dropping even more. So now we've gone from sequencing DNA from people to sequencing the DNA or the instruction book of cells in tumors. And so one of the projects I'm getting launched is sequencing tumors from individuals with NF1, NF1-associated tumors. And the goal of this is to try to understand what mutations or what changes in DNA or the instruction book have occurred in the tumors, and that way we can hopefully target better medications and trials to those tumors. And this is going on not only in NF1, but of many, many, many different tumor types around the world. Again, another enormous international undertaking. Lots of talk about whole body MRI, trying to look for these plexiform neurofibromas, and PET scanning. And PET scanning is a way of looking for metabolically active tumors in the body. It's a way of taking a snapshot of the body with MRI or CT and seeing which of these tumors is using up more sugar than they should is a measure of how active they are. And tumors that are really, really active are more likely to be malignant or cancerous than benign. It's got a little ways to go, but it's, again, an exciting, evolving technology. One of the big themes of this conference was the use of mouse models. I'm not a mouse modeler, but the original mouse model was published in NF1 in the early mid-1990s. I think it was 1993. And now it seems like every time I go to this conference, there are new mouse models. And you may reasonably say, well, why should I care about mouse models? But the important thing is that mouse models are the key to performing good clinical trials. If you can fix NF1 in a mouse, then increases your likelihood of fixing it in humans. There are clinical trials, believe it or not, to treat learning disabilities using the cholesterol medication lovastatin. And there's also seems to be greater recognition of learning problems and attention deficit problems in children and adults with NF1. I think this is my second to last slide here, ways to get involved. Always looking for people to get involved in research. If you go to clinicaltrials.gov, which I'll have the website up in a moment, you can plug in where you live and the disorder you have and see if there's any trials in your local area that interest you. You can see the most common ones are involved with tumors. The Department of Defense through the Army has something called the Congressionally Directed Medical Research Programs, and this is for a whole variety of different medical problems, including NF1. And this translates to millions of dollars of funding every year for a variety of disorders, including NF1. It's a big, important funding mechanism, especially for clinical trials in NF1. Voting your support through writing your senator or congressman can be very helpful. And then, of course, the local chapter of NF Inc. I'm sure would be glad to have as much participation as possible. Briefly, at NIH, there's my colleague, Dr. Wiedemann, who is a pediatric oncologist, a children's cancer doc, who works on NF1 in children and young adults. She's interested in plexiform neurofibromas. My colleague, Carleen Riley, is interested in mouse modeling of NF1, trying to understand, try to find these modifier genes, what makes NF1 better or worse in some people. Dr. Asthagiri is at NINDS, which is National Institute of Neurologic Disease and Stroke. He's a neurosurgeon and focuses on NF2. And there I am at the bottom, interested in NF1 in adults. I've worked on finding modifier genes for many years, as has Dr. Riley, and then, as I mentioned earlier, tumor genomes by these new exciting technologies. And then I'll leave this up as a last slide. Presumably you know about NF Inc. and the Children's Tumor Foundation. I found, unfortunately, a number of the patients I've seen over the years who don't have good health insurance. That website can be a useful way to find health insurance or low-cost, find health insurance, find low-cost care. If you're interested in getting involved with the research, clinicaltrials.gov is a wonderful site. And then, as I mentioned earlier, the Department of Defense NF program, the website is there. So I hope that's been a helpful overview of some practical medical nuggets of NF1 and some idea about what's going on in the research field and into the future. And I think what we're going to do is have Kim collect the questions, and I try to answer as many as I can in the time that we have.
Well, thank you very much, Dr. Stewart. I'm sure people are applauding from the east to the west coast for the great information that you've given us this evening. I'd like to just go and say thanks for mentioning contacting your congressman. I know most of the people that are on the webinar tonight do get the emails from us, and I would just like to strengthen Dr. Stewart's statement that really is how millions of dollars are getting into the NF research community. And in order for those dollars to continue, especially in our economy, it really does require all of us to be making that contact with our senators and our congressmen, telling them that it is important to us, for if we don't do that, then who would? We do have several questions that have been typed in, and I'll go ahead and read them. There's also a way, if you would like to ask a question verbally, there's a little hand next to your name there. If you push the little hand button, then I'll be able to unmute your phone and ask a question. So now, Dr. Stewart, I'm looking at some of the questions that have come in during your presentation, and I see 3 of them that are asking questions about GI issues with NF. Some are asking, can NF be in the digestive tract? Other people are asking, if you have GI issues, could that be part of someone who's having a hard time making a diagnosis of NF? Could that be considered part of the criteria for diagnosing NF?
So those are all great questions. So NF in the GI tract is a little bit less studied than NF's effect on other organ systems. You can definitely get plexiform neurofibromas in the bowel, in the intestines, and you can develop neurofibromas in the intestines. It doesn't seem to cause too many problems in my experience. I've had people come in for colonoscopies, and on the colonoscopy there are a few neurofibromas that are seen, and they're biopsied, and the pathology shows them to be a neurofibroma, but they haven't been causing much pain, and they haven't been bleeding. They're just growing there like they grow on the skin or anywhere else in the body. So neurofibromas can grow wherever they want, whenever they want, and get as large as they want, and it looks like the intestines or the GI tract is no exception to that. The other interesting thing with the GI tract is there's a set of tumors called gastrointestinal stromal tumors, or GISTs, G-I-S-T, and these are uncommon tumors that can grow really anywhere in the GI tract, and they can cause some bleeding, and they can grow large and cause obstruction, and they can cause pain. We wrote a paper a couple years ago that showed that these GISTs were associated with NF1, but they remain relatively understudied because it's hard to get access to them, and I think a lot of the times they grow in people and they're asymptomatic. They don't cause any problems. So there's still a lot of work that needs to be done. The last thing about GI issues is if you look in the textbooks and things, it says people with NF1 can be constipated, or constipation is a feature of NF1. And I confess I've asked a lot of people about this over the years, and I can't say I've been impressed with that it's a huge problem, but it's in all the textbooks. And there's some kind of theoretical reasons about why that may be the case, that the way NF1 affects the innervation of the bowel, and it may slow things up a bit. But the good news is it's usually treated relatively easily with standard over-the-counter laxatives, that kind of thing.
Okay, then thank you, Dr. Stewart. I'm going to open Renee Grassman's phone. Renee, are you there? Renee, can you hear me? She's the one who put her hand up first today. Well, maybe she can't hear. Let's go on to another one, see if I can get another one to open up. Okay, this is for Judy Schrott, S-C-H-R-O-T-T. Judy, can you hear me? Judy, your phone is open. Can you hear me? Well, I'm not sure why that's not working, so let me go back to another written question right here, and we'll try another one on the phone in a minute. This one here is, any research being done between the correlation of UBOs and MRIs and latent development of actual brain tumors or neurofibromas?
So UBOs are as an abbreviation for unidentified bright object, which is a finding that's seen on MRI in children, often children, and it's caused lots of investigation over the years about what exactly these UBOs are and what they mean. And they've been studied, and some researchers have concluded that they cause, they're associated with learning problems, and other people say no, they're not associated with learning problems. UBOs can be helpful in diagnosing NF1, although they're not on the standard diagnostic criteria, and they tend to get better with time. So if you image a child at age 10 and then again at age 20, they tend to fade. And there have been a couple of examples in which a UBO has either been biopsied or the person unfortunately has died, and then the tissue was obtained right from where that UBO is located. And it looks like there was some abnormalities or differences in myelination, which is the sort of the insulation around the nerves, and that, and also some swelling or fluid in the nerve at that point. But I'm not aware of any association with those and increased risk for developing tumors of any kind. The understanding that we have is that they seem to be a marker for NF1, but they don't seem to cause any problems unto themselves. And as I said, they can be useful for diagnosing the disorder, but I think the jury is still way out on if they're actually associated with anything significantly worrisome. Like I said, some people say, well, they're associated with learning problems, and other people say they're not. So it's an active field of investigation.
Okay, thank you, Dr. Stewart. Now I have figured out why some of the questions we couldn't get through. So if you use that conference call number, then I can unmute your phone and you can speak to me and I can get the question. But if you're listening by computer, then you have to type the question for me. But here's somebody. I think Debbie, can you hear us now? Debbie, you're on the phone. Can you hear us? Debbie from California?
I can hear.
Okay, go ahead and ask your question.
Hold on, I gotta. My son, who's 9, has been with inconsistent high blood pressure, and we've been seeing a nephrologist for 2 years. He's had the 24-hour urine test done. He's had some protein show up in a few of the tests, but not all of them. He's had an ultrasound done and an MRI. We just saw the nephrologist last week, and they're thinking they need to put him on high blood pressure, but they're not sure. He's on Lupron, Nexium, Concerta, Ditropan, and BSL, and also Augmentin. He has sweaty hands, palms at times, but nothing else as far as headaches and stuff go. And we were just kind of concerned about putting him on high blood pressure, and just wanted to see if you had any suggestions.
Yeah, well, it sounds like he's had a workup, and it sounds like there's been no satisfying explanation as to what's going on. I'm not a pediatrician by training. Background's adult medicine. My understanding is that there are plenty of safe medications for controlling high blood pressure in children. And the other thing that I did not mention with my slide on this is that a rare cause of high blood pressure in children with NF1 is something called a coarctation of the aorta, or it's narrowing of the aorta. I would imagine that would have been picked up a while ago because of it can cause murmurs and some other things, but that's also on the list of unusual causes for high blood pressure in children. So that's something to look into. The issue with the renal artery stenosis, which is the blockage of the blood vessels supplying the kidneys, it can be really hard to diagnose even with MRI, and sometimes the most definitive test is to actually put a little catheter in there and squirt some dye to actually image the blood vessels themselves. So it's a more invasive procedure, but it gives you a definite answer. The other thing that can be done while the interventional radiologist is in there doing that is they can actually sample renin, which is a chemical produced by the kidney, and if you see different levels of renin on the 2 different sides, that suggests that there may be that kind of blockage. So that would be a workup for the renal artery stenosis. And then for the pheochromocytoma, it's the 24-hour urine, as you mentioned, and there are some blood tests that can be done, often in conjunction with 24-hour urine and then imaging. There's also a nuclear medicine study to look for the pheochromocytomas called an MIBG, I believe, because sometimes those pheochromocytomas aren't where they're supposed to be. They're not always on the adrenal gland. They can be sort of up and down the spine in different places in rare scenarios. So that may be the situation that your son's running into.
Okay, great. We'll look into that. Thank you.
Yep.
Right. There's a couple of others here that I'd like to combine here that are written in, and that is about the genetics of NF. One is a lady who has NF. Her parents don't have NF, and she wants to know if that changes the complications that she's going to have with NF. Does it make it more severe or not? And then, well, go ahead, Dr. Stewart, with that one, and I'll scan.
Okay. So this issue of severity of NF1, it does not seem to be influenced or affected by whether you have a parent who's affected with NF1 or not. So we know, as I said earlier, that NF1 is very common, and about half the people with NF1 are the first person in their family to have it, and the other half inherited the disorder from either their mother or their father. And the people who inherited it from their parents have the same range and severity of symptoms and problems as the people who developed it independently on their own. And then you can look at that even more closely and say, well, if for the people who inherited from a parent, does it matter if they inherited from their mom or from their dad? And that doesn't seem to make any difference either. So the answer is I would not expect a family history to be predictive in any way of severity of NF1. There are a few exceptions to that, but that's mostly related to the type of mutation in the gene, and that's more of a separate question. But as a general rule, whether you have NF1 from a parent or develop it as the first person in your family, it does not affect the severity of the disorder.
And here's the other one, Dr. Stewart. What is the percentage of people with mild NF, and if it's mild, will it stay mild? And another part is NF1 and Marfan's related?
So NF1 and Marfan syndrome are not related. Marfan, that's what you said, Marfan syndrome, right?
Yeah.
Yeah. Marfan syndrome is another genetic disorder, and that's from mutations in the gene called fibrillin 1. I many years ago, see a child with NF1 and Marfan syndrome. So NF1 is common enough that you see overlap with other disorders. It's pretty rare, and it's something that gets written up as a case report. But no, they're not related. Two different genes, two different chromosomes. With the issue with mild NF, this is something that's caused all sorts of arguments and discussion over the years about, well, how do you define mild? Is it mild NF, not so many tumors, not so many learning problems, no optic pathway glioma, no plexiforms? You can define mild in many, many, many ways. I think it is true that if you look on the internet or in a textbook, you see these very dramatic pictures of people with NF1, lots of tumors and very disfiguring plexiform neurofibromas. And I feel safe saying that that tends to be the minority rather than the majority. I think there are a lot of people out there with NF1 who, yes, they have some tumors and they may have some learning problems and they have some of the other issues that we described, but they live their lives and they live it with NF1. They're not necessarily defined by it. And so if you mean mild by that, yes, I'd say that there's a lot of people out there like that. The other, with regards to does it get worse over time, we know that the neurofibromas grow at their own pace. And in my experience, if you have a lot of neurofibromas at age 20 compared to people your age, you'll probably have a lot compared to people your age when you're 40 or 50 or 60. And the reverse is true. If you have not so many compared to other people with NF1 at age 20, you probably won't have so many compared to as you get older. as a general rule, there's no guarantees. And again, one of the things we're trying to do is figure out what other genes are playing a role in determining severity. That's an interest of myself and then some other research groups. And so I would hope at some point in the future we could come up with a gene test or a way of making these predictions, because it's it's an important issue.
All right, then I'm going to try to go back to the phone. This time I've unmuted Harold Daniels Jr. Harold, can you hear us?
Yes, I can.
Well, go ahead and ask your question.
Doc, I have two questions. The tumors that grow underneath your nail, can they grow on the outside but very close?
Yes, they can. I had a picture of one, of a woman who had one of these tumors growing outside of her nail and sort of protruding through the skin. That seems to me less common than under the nail and not at all obvious, but it definitely can happen, yes.
Okay, and my second question is the what is it called, the plastio tumors that grow on your spine? Or is that just limited to the lower lumbar, or can it grow up into the thoracic? On your back?
Yeah, the tumors on the spine, whether they're neurofibromas or plexiform neurofibromas,
right,
they can grow really wherever they want. In my experience, the middle part of the spine seems to be somewhat spared compared to the lower part, but that's just my experience. That doesn't necessarily mean it's not necessarily what everyone sees.
Right. So it could grow like up between the scapulas then.
Yeah. Oh yes. Yeah. And the only way to find out is to be certain is to do the appropriate MRI. MRI is usually the best thing.
Right. So the older you get, would it be recommended that I would have like an MRI of my back? Because in the past, basically they would just give me the MRI of my brain to make sure I had nothing growing behind my optic nerve.
Right. And once, if you have the brain, often, let me back up a second, it's controversial, but some places, some medical centers do MRIs of children to make sure they don't have any optic pathway glioma, but the development of an optic pathway glioma in the brain is very uncommon once people are out of childhood.
Okay.
And so unless there's a new symptom that develops, there's really no need for regular MRIs of the brain. And I would say the same thing's true of spine. There's no need for regular imaging of the spine unless there's some active problem that's being followed.
Right. Well, I have one, and I just wanted to know when I approach my doctor again, they're saying, well, we better get on this, and maybe that's part of my problem. That might be causing my discomfort.
Well, they can certainly, yeah, they can certainly grow or change over time, and so it's reasonable to study them over time, especially if you're having persistent symptoms or problems from it. Yes.
All right, right. So I better get on and get a neurologist. Thank you very much, Doc.
Sure. Yep.
Thank you. We'll go for one more question, I think, here, and then, like Dr. Stewart said, other questions could be emailed here to us at admin at NF Network, and we'll go ahead and send them on to Dr. Stewart. It's really hard to pick this last question, I guess. Oh, there's so many good ones here. I guess I'll do this one that came in last because it's about participating in research. She says, I have 6 children. My 5th child has NF1. To my knowledge, none of my other 5 do. My 2 oldest daughters are in college at the University of Michigan focusing on medicine. They are currently starting their research and are doing research in the NF field. One of them definitely plans to go into neurology in the NF field. Both of my daughters are extremely bright and graduated in the top 10 in their class at private schools with higher standards. Is there an opportunity for them to participate in any of the research studies currently underway for NF1? Besides being very bright girls and an asset to any research team, they are passionate about NF and helping their little sister have a better quality of life and improving the quality of life in her offspring down the road. My 2 daughters wanted to participate in this webinar this evening, but unfortunately we're not able. Is it possible to get a copy of the webinar for my daughters, including the audio? So yes, we are recording the the talk tonight, but we will have to talk to Dr. Stewart. And will these slides be available?
I can make the slides available. That's not a problem. Yeah.
Terrific.
Absolutely.
Yeah. All right, well, I guess that really has taken up our time. It's 8:30 now. And like I said, if you still do have additional questions, go ahead and send them to us at admin@NF Network. I apologize for not being able to get to everybody's questions, but we do thank everybody for their participation tonight. You'll get an email from us with a survey, so we'd appreciate any feedback that you can give to us. We've just really started this program. This is our 3rd webinar, and we plan to continue them. And the next one on NF1 will be in September. Thank you, Dr. Stewart, very much.
My pleasure. Thank you.
For your time this evening and giving us all this great information. Thanks again.
My pleasure.